RN Link presents hospital-acquired conditions. The presentation offers one continuing education unit approved by Board of Registered Nursing and accepted by Association of Clinical Documentation Improvement Specialists and American Health Information Management Association. Objectives. At the end of this training session, the participant will learn: what are hospital-acquired conditions? Define each HAC. Understand why HACs are an important part of the CDS reviews. Determine POA status when HACs are listed in the medical record documentation. Review case studies for HACs. Question and answers. Disclaimers. This material is designed and provided to communicate information about clinical documentation, coding, and compliance in an educational format and manner. The presenter is not providing or offering legal advice but, rather, practical and useful information and tools to achieve compliant results in the area of clinical documentation, data quality, and coding. Every reasonable effort has been taken to ensure that the educational information provided is accurate and useful. Applying best practice solutions and achieving results will vary in each hospital/facility and clinical situation. What are hospital-acquired conditions? Complications that a patient develops within the hospital setting. Present on admission indicator is listed as N, not present on admission within the claim form. Prevention of HAC diagnoses/procedures is the key. Part of the value-based purchasing program, developed by CMS. CDS can identify and help alleviate possible HACs on the claim form by querying the provider during the concurrent review process. Hospitals can incur a monetary penalty for HACs listed on the claim forms. Example: hospitals will not be paid for the HAC diagnoses or procedures that occurred within the hospital setting that are not present on admission. HAC Reduction Program. Hospitals are ranked on their total rate of preventable conditions such as surgical site infections and catheter-associated UTIs. 25% of hospitals with the highest rates of preventable conditions receive a 1% reduction in Medicare fee-for-service inpatient payments. Hospitals that are exempt from this program include critical access hospitals, rehabilitation hospitals and units, long-term care hospitals, psychiatric hospitals and units, children's hospitals, prospective payment system, exempt cancer hospitals, Veterans Affairs hospitals, short-term acute care hospitals within the U.S. territories, Guam, Puerto Rico, U.S. Virgin Islands, Northern Mariana Islands, and American Samoa. It is comprised of CMS PSI 90, discussed in our other presentation, and CDC hospital-acquired infections. Hospital-acquired infections include central line-associated bloodstream infection, catheter-associated urinary tract infections, colon and abdominal hysterectomy surgical site infections, methicillin-resistant Staphylococcus aureus bacteremia, and Clostridium difficile infection. Listing of hospital-acquired conditions. HAC 01, foreign object retained after surgery. HAC 02, air embolism. HAC 03, blood incompatibility. HAC 04, stage 3 and 4 pressure ulcers. HAC 05, falls and trauma. HAC 06, catheter-associated urinary tract infection, UTI. HAC 07, vascular catheter-associated infection. HAC 08, surgical site infection mediastinitis after coronary bypass graft. HAC 09, manifestations of poor glycemic control. HAC 10, deep vein thrombosis/pulmonary embolism with total knee or hip replacement. HAC 11, surgical site infection, bariatric surgery. HAC 12, surgical site infection, certain orthopedic procedures of spine, shoulder, and elbow. HAC 13, surgical site infection following cardiac implantable electronic device procedures. HAC 14, iatrogenic pneumothorax with venous catheterization. HAC General Reporting Guidelines. POA indicator reporting is mandatory for all claims involving inpatient admissions to general acute care hospitals or other facilities. POA is defined as present at the time the order for inpatient admission occurs. Conditions that develop during an outpatient encounter, including emergency department, observation, or outpatient surgery, are considered POA. A POA indicator must be assigned to principal and secondary diagnoses, as defined in Section 2 of the Official Guidelines for Coding and Reporting, and the External Cause of Injury Codes. CMS does not require a POA indicator for an external cause of injury code unless it is being reported as an other diagnosis. Issues related to inconsistent, missing, conflicting, or unclear documentation must be resolved by the provider. If a condition would not be coded and reported based on uniform hospital discharge data set definitions and current official coding guidelines, then the POA indicator would not be reported. On this slide, you can see the estimated costs associated with HACs, which include the number of studies, range of estimates and additional cost estimate, 95% confidence interval. More robust literature and higher overall additional costs were found for infectious HACs compared to non-infectious HACs. The least expensive infectious HAC is catheter-associated urinary tract infections, $13,793, and the most expensive is central line-associated bloodstream infections, $48,108. The studies include adverse drug events, catheter-associated urinary tract infections, central line-associated bloodstream infections, falls, obstetric adverse events, pressure ulcers, surgical site infections, ventilator-associated pneumonia, venous thromboembolism, C. difficile infections. HAC additions, diagnoses. HAC code I2603, MCC, cement embolism of pulmonary artery with acute cor pulmonale. HAC code I2604, MCC, fat embolism of pulmonary artery with acute cor pulmonale. HAC code I2604, CC, cement embolism of pulmonary artery without acute cor pulmonale. HAC code I2696, CC, fat embolism of pulmonary artery without acute cor pulmonale. HAC additions, procedures. HAC code XRGA0EA, fusion of thoracolumbar vertebral joint using facet joint fusion device, paired titanium cages, open approach, new technology group 10. HAC code XRGB0EA, fusion of lumbar vertebral joint using facet joint fusion device, paired titanium cages, open approach, new technology group 10. HAC code XRGC0EA, fusion of two or more lumbar vertebral joints using facet joint fusion device, paired titanium cages, open approach, new technology group 10. HAC code XRGD0EA, fusion of lumbosacral joint using facet joint fusion device, paired titanium cages, open approach, new technology group 10. The next following slides are examples and description each hospital acquired conditions. HAC 01, foreign body retained after surgery. T81511A, C, adhesions due to foreign body accidentally left in body following infusion or transfusion, initial encounter. T81518A, C, Adhesions due to foreign body accidentally left in body following other procedure, initial encounter. T81528A, C. Obstruction due to foreign body accidentally left in body following other procedure, initial encounter. Note, if the foreign body is removed during the same hospitalization, it does not count as a HAC on the claim form. HAC 02, air embolism. T800XXA, M, air embolism following infusion, transfusion and therapeutic injection, initial encounter. Note, this would be listed as a HAC on the claim forms for air embolisms that follow any infusion, transfusion or therapeutic injections. HAC 03, blood incompatibility. T8030XA, C, ABO incompatibility reaction due to transfusion of blood or blood products, unspecified, initial encounter. T80319A, C, ABO incompatibility with hemolytic transfusion reaction, unspecified, initial encounter. T8039XA, C, other ABO incompatibility reaction due to transfusion of blood or blood products, initial encounter. Note, reactions include hemolytic transfusion whether acute or delayed, other incompatibility reaction. HAC 04, Stage 3/Stage 4 pressure ulcers. L89124M, pressure ulcer of left upper back, Stage 4. L89133M, pressure ulcer of right lower back, Stage 3. L89513M, pressure ulcer of right ankle, Stage 3. L89514M, pressure ulcer of right ankle, Stage 4. Note, sites include elbows, buttocks, sacral region, hips, ankles, heels, other sites. HAC 05, falls and trauma. S02641B, C, fracture of ramus of right mandible, initial encounter for open fracture. S06898A, M, other specified intracranial injury with loss of consciousness of any duration with death due to other cause prior to regaining consciousness, initial encounter. S32401A, M, unspecified fracture of right acetabulum, initial encounter for closed fracture. S32502A, C, unspecified fracture of left pubis, initial encounter for closed fracture. Note, too many HAC diagnoses to add, also included under trauma diagnoses, crushing injuries, burns/corrosions, frostbite, asphyxiation. HAC 06, catheter-associated urinary tract infection. T83511A, C, infection and inflammatory reaction due to indwelling urethral catheter, initial encounter. T83518A, C, infection and inflammatory reaction due to other urinary catheter, initial encounter. Note, additional diagnoses would also be listed on the claim form with the above HAC diagnosis: acute pyelonephritis, candidal cystitis, pyonephrosis. HAC 07, vascular catheter-associated infection. T80211A, C, bloodstream infection due to central venous catheter, initial encounter. T80212A, C, local infection due to central venous catheter, initial encounter. T80218A, C, other infection due to central venous catheter, initial encounter. T80219A, C, unspecified infection due to central venous catheter, initial encounter. Note, any of the above diagnoses will be listed as a HAC on the claim form. HAC 08, surgical site infection/mediastinitis after coronary bypass graft. 0210088, Y, bypass coronary artery, one artery from right internal mammary with zooplastic tissue, open approach. 0211483, Y, bypass coronary artery, two arteries from coronary artery with zooplastic tissue, percutaneous endoscopic. 02114K3, Y, bypass coronary artery, two arteries from coronary artery with non-autologous tissue substitute, percutaneous endoscopic approach. 02120A3, Y, bypass coronary artery, three arteries from coronary artery with autologous arterial tissue, open approach. Note, if mediastinitis is documented post-procedure, this will be listed as a HAC on claim form, other diseases of mediastinum, not elsewhere classified. HAC 09, manifestations of poor glycemic control. E0800, M, diabetes mellitus due to underlying condition with hyperosmolarity without nonketotic hyperglycemic hyperosmolar coma. E0810, M, diabetes mellitus due to underlying condition with ketoacidosis without coma. E0910, M, drug or chemical-induced diabetes mellitus with ketoacidosis without coma. E1310, M, other specified diabetes mellitus with ketoacidosis without coma. Note, the diagnoses listed above with other numerous diagnoses will be listed as a secondary diagnosis that occurred during the inpatient hospitalization. It would be listed as a HAC on the claim form. HAC 10, deep vein thrombosis/pulmonary embolism with total knee replacement. 0 SR 9019, Y, replacement of right hip joint with metal synthetic substitute, cemented, open approach. 0 SR 902Z, Y, replacement of right hip joint with metal on polyethylene synthetic substitute, open approach. 0 SRB 039, Y, replacement of left hip joint with ceramic synthetic substitute, cemented, open approach. 0 SRC 0 EZ, Y, replacement of right knee joint with articulating spacer, open approach. 0 SRD 0 EZ, Y, replacement of left knee joint with articulating spacer, open approach. Note, whether it is any type of PE, saddle, subsegmental, or DVT that develops post-procedure, will be listed as a HAC on the claim form. HAC 11, surgical site infection, bariatric surgery. 0D16079, Y, bypass stomach to duodenum with autologous tissue substitute, open approach. 0D160Z9, Y, bypass stomach to duodenum, open approach. 0D164Z9, Y, bypass stomach to duodenum, percutaneous endoscopic approach. 0D168ZL, Y, bypass stomach to transverse colon, via natural or artificial opening endoscopic. Note, post-procedural retroperitoneal abscess, infection following procedure, whether superficial, deep or organ-related with PDX of morbid obesity, will be listed on the claim form as a HAC. HAC 12, surgical site infection, certain orthopedic procedures of spine, shoulder and elbow. 0 RG 0371, Y, fusion of occipital cervical joint with autologous tissue substitute, posterior approach, posterior column, percutaneous approach. 0 RG 2070, Y, fusion of two or more cervical vertebral joints with autologous tissue substitute, anterior approach, anterior column, open approach. 0RG04Z, Y, fusion of right sternoclavicular joint with internal fixation device, open approach. 0RGM0JZ, Y, fusion of left elbow joint with synthetic substitute, open approach. Note, post-procedural retroperitoneal abscess, infection following procedure, whether superficial, deep or organ-related would be listed as a HAC on the claim form. HAC 13, surgical site infection following cardiac implantable electronic device procedures. 02H43NZ, Y, insertion of intracardiac pacemaker into coronary vein, percutaneous approach. 02H73KZ, Y, insertion of defibrillator lead into left atrium, percutaneous approach. 0JH604Z, N, insertion of pacemaker, single chamber into chest subcutaneous tissue and fascia, open approach. 0JWT3PZ, Y, revision of cardiac rhythm-related device in trunk subcutaneous tissue and fascia, percutaneous approach. Note, post-procedural retroperitoneal abscess, infection following procedure, whether superficial, deep or organ-related would be listed as a HAC on the claim form. HAC 14, iatrogenic pneumothorax with venous catheterization. 02HS43Z, N, insertion of infusion device into right pulmonary vein, percutaneous endoscopic approach. 05HN33Z, N, insertion of infusion device into left internal jugular vein, percutaneous approach. 05H633Z, N, insertion of infusion device into left subclavian vein, percutaneous approach. Note, post-procedural pneumothorax will be listed as a HAC on the claim form if it develops during any venous catheterization procedure. Importance of HACs to CDI. Rationale. Review of the medical record by CDI specialists incorporates all diagnoses that give an accurate description of the hospitalized patient, promoting the highest specificity for each diagnosis, including HACs. Consider the review as a risk-based approach based upon the value-based purchasing program founded by CMS. Risk adjustment has become a focus of CMS, private insurance companies as well as healthcare organizations and individual providers. This, in turn, focuses on risk adjustment payments to hospitals and providers. This type of payment is overtaking the traditional fee-for-service payments. More than 78% of CDI departments review for POA status and mortality reviews, observed/expected outcomes ratio. Here's an in-depth examination of the importance of clinical documentation improvement. 1. Quality reporting and public accountability. The Centers for Medicare and Medicaid Services tracks hospital-acquired conditions as part of its evaluation of hospital performance, example, HAC reduction program. Inadequate documentation of conditions present on admission may result in misleading quality metrics, which do not accurately reflect a hospital's standard of care. CDI specialists play a crucial role in determining whether a condition existed at admission or developed during the hospital stay, thereby helping to avert unwarranted penalties. 2. Financial implications and reimbursement. Under CMS guidelines, specific HACs do not qualify for increased diagnosis-related group payments if they are not classified as POA, regardless of whether they involve complications or comorbidities. A thorough CDI review guarantees the proper sequencing and POA status, safeguarding hospitals against revenue loss and compliance risks. 3. Adherence to regulations and risk management. Insufficient documentation and coding of hospital-acquired conditions may lead to audits, heightened compliance scrutiny, or even accusations of fraud and abuse. Clinical documentation improvement specialists are vital in ensuring that medical records are accurately and defensibly documented, which is critical for successfully navigating payer audits and reviews. 4. Impact on patient safety indicators and risk adjustment. Many HACs are linked to the AHRQ patient safety indicators. Incorrectly classifying conditions as HACs can result in misleading PSI outcomes. Comprehensive CDI reviews can support PSI appeals by clarifying clinical evidence, for example, verifying that an infection is not truly catheter-associated or that a pressure ulcer existed at the time of admission. 5. Educational role and provider engagement. CDI specialists play a crucial role in informing healthcare providers about the importance of hospital-acquired conditions and emphasize the necessity for precise and timely documentation, including pressure injuries, catheter-associated UTIs, and falls. They help providers comprehend how accurate documentation influences both patient safety initiatives and the institution's standing. 6. Clinical accuracy and care continuity. Accurate identification of HACs is vital for effective clinical profiling and maintaining continuity of care. For instance, differentiating between community-acquired and hospital-acquired infections can significantly influence strategies for antibiotic stewardship and infection control. Summary. HACs are significant for CDI as they impact public reporting and quality metrics, hospital reimbursement and DRG categorization, compliance with legal and regulatory standards, accuracy of PSIs and related appeals, documentation practices of physicians, comprehensive patient safety efforts. CDI specialists play a crucial role in minimizing financial penalties, enhancing data precision, and fostering high-quality patient care. What to do if a HAC is present? From a CDI perspective, the CDS should clarify if a diagnosis/condition was POA or not POA via query opportunities. It is up to the healthcare provider to make that determination. All diagnoses, including HACs. Keep in mind that there are numerous risk adjustment models available to hospitals and providers, as well as many quality and patient outcome benchmarking programs that track HACs within the inpatient setting. This slide shows CMS quality measures as follows. Hospital ranking, which includes CMS Hospital Compare, U.S. News Best Hospitals, Newsweek Best Hospitals, Fortune IBM Watson, Becker's Hospital Review, Health Grades, and Leapfrog. Next is the CMS Quality Measure Programs. As you can see, HACs is in this category, as well as HRRP, IQR, NQF, MIPS, MACRA, SCIP, Core Measures, AHRQ-PSI, ECQMs. RA payment models are Medicare Advantage, Affordable Care Act, Medicaid, and various commercial plans. On the overlapping focus areas, HACs is in the mix, and all other areas as listed on the slides. Then the private benchmarking solutions like Visinit, Midas, Advisory Board, Health Catalyst, and Leapfrog. Present on admission status. POA indicators. Y is present on admission. N is not present on admission. U is insufficient documentation to determine if the condition was present on admission. W is clinically undetermined. Note, providers may believe they only have a yes or no response when querying for POA status. Keep in mind that clinically unable to determine can be utilized on the claim form as W listed above if the providers really do not know if the specific diagnosis was POA or not POA. Case studies relating to HAC diagnosis. Case study number 1. 78 years old female presented to the ER with shortness of breath, rhonche, and cough. She resides at a skilled nursing facility, where she was running a temperature of 102.4. Current vital signs are temp of 101.8, pulse of 115, respiration of 24, BP of 101/56, and SpO2 of 90% on room air. Past medical history includes COPD, hypertension, hyperlipidemia, and hypothyroidism. ER provider clinical impression: pneumonia, likely bacterial based on fever, shortness of breath, leukocytosis of 18.4, lactic acid 2.5 and chest X-ray positive for consolidation right upper lobe. Initiated IV azithromycin and IV cefepime, to be admitted under medical hospitalist team. Attending provider assessment/plan, presented with shortness of breath, cough, and temperature likely related to gram-negative pneumonia. Continue IV cefepime and IV azithromycin, recheck chest X-ray in 2 days, recheck CBC tomorrow and lactic acid. Hospital day 2, attending provider progress note indicates, rapid response called for hypotension, received 2 liters normal saline solution without effect, to be transferred to ICU for vasopressor drip. BP still hovering around 79/48 to 85/52. Critical care provider impression: septic shock secondary to gram-negative pneumonia. Originally admitted to telemetry unit by medical hospitalist team, rapid response called today due to ongoing hypotension, transferred to ICU and initiated levofed drip. Hospital day 4 critical care progress note indicates, hypotension resolved, off levofed drip, continue gentle IV fluid hydration, patient alert and responding to simple questions and commands, daughter at bedside, does indicate patient has mild memory impairment from a previous stroke, no other deficits noted, blood cultures positive for Klebsiella. Continue IV cefepime and IV azithromycin for 7-day course, stable to be transferred out of ICU to step-down unit. Medical hospitalist team notified. What is the PDX? Is it COPD, septic shock, gram-negative pneumonia, hypertension or hypothyroidism? Let's check it out. Per provider documentation, for now it is gram-negative pneumonia. It may change to septic shock once query is sent to clarify if sepsis is present on admission. Although the clinical indicators for sepsis is present on admission, example is the elevated temperature, heart rate as well as elevated WBC and lactic acid. ER and initial assessment documented by the provider is gram-negative pneumonia. It is recommended that query for sepsis as present on admission be submitted to the provider for documentation to avoid audit by the payors and possibly denial. What are the CCs, MCCs? Let's check it out. So far, per present documentation, septic shock is MCC. No CCs found. Now let's go back to the documentation to find out if there are any potential queries. Let's check it out. As discussed on the previous slides, we can query for sepsis, septic shock as present on admission. Another potential query is COPD exacerbation. Per documentation, the SpO2 was 90%. Follow-up for oxygen usage. Was the patient on high-flow oxygen, on BiPAP, CPAP, or was on ventilator since the patient presented with shortness of breath, rhonchi and cough symptoms and has a history of COPD? ACDIS can also follow up if the patient is using oxygen continuously at home, so we can possibly query for chronic respiratory failure since the patient has COPD. Another potential query is acute respiratory failure if there is no chronic respiratory failure. Check out if clinical indicators are present for this diagnosis. Clinical indicators may include but not limited to ABG results, increased oxygen usage, BiPAP, CPAP or ventilator assist, provider documenting acute respiratory insufficiency, etc. It is important to query also the specificity of the respiratory failure, whether it is hypoxemic, hypercapnic or combination of both. However, if there are clinical indicators for chronic respiratory failure and provider documented chronic respiratory failure, we can query for acute on chronic respiratory failure. Sample present on admission query for septic shock. Query clinical indicators. Diagnosis, septic shock. Hospital Day 2 attending progress note. Attending provider progress note indicates, rapid response called for hypotension, received 2 liters of normal saline solution without effect, to be transferred to ICU for vasopressor drip. BP still hovering around 79/48 to 85/52. Diagnostic tests, admit workup, fever 101.8, WBC 18.4, chest X-ray right upper lobe consolidation. Lactic acid 2.5. Treatment, IV cefepime, IV azithromycin, chest X-ray, CBC. Based upon the clinical indicators above and your medical judgment, please clarify if septic shock was present on admission. Yes. No. Unable to clinically determine. Sample query opportunities for pneumonia. Although the pneumonia is well documented on this case, this is just an example for querying pneumonia. Clinical indicators. Symptoms documented as fever, chills, shortness of breath, pleuritic chest pain, dysphagia, choking, history of CVA, PEG or NGT feeding. Physical exam documented as rales, rhonchi, dullness, chest wall splitting, pleural rub. Diagnostic tests, chest X-ray with consolidation, infiltrate or interstitial changes and or pleural effusion, positive blood and or sputum cultures, may be negative, WBC low, normal or elevated. Positive aspiration per speech evaluation and swallow study. Treatment includes IV antibiotic, based on suspected organism, swallow study to confirm aspiration, supplemental oxygen. Specificity. Type. Aspiration, check if there was CVA, dysphagia, swallow study to confirm aspiration. Bacterial, organism if known. Gram-negative, which is usually treated with vancomycin or Zosyn. Or viral. Case study number 2. 48-year-old male directly admitted to the hospital for elective bariatric surgery. His current BMI is 52.4, has a history of hypertension, prior history of right lower extremity DVT on Eliquis and morbid obesity due to excess calories. Hospital day 1, patient undergoes sleeve gastrectomy without initial complications. Hospital day 2, patient experiences dizziness, hypotension, tachycardia. Workup reveals acute drop in H&H from pre-op testing 15.6/35.6 to current testing of 8.6/22.1. CTAP reveals hyperdense attenuation, suspicious for hemorrhage. Patient urgently taken back to OR on hospital day 2. Surgeon's findings indicate retroperitoneal hematoma noted in the abdominal muscle. Status post-evacuation. No other signs of bleeding noted from any blood vessel or anastomosis. Hospital day 3. Patient feels okay, not as dizzy as I was yesterday. Discussed the complication that occurred with the retroperitoneal hematoma. Patient confirmed that he did not take his Eliquis 5 days prior to surgery. We have not restarted it yet due to hemorrhage, with H&H stabilized to 10.3/29.8 post 2 units packed RBC transfusion. We'll recheck H&H tomorrow. Let's review for the what is the principal diagnosis, secondary diagnoses, or any query opportunities. What is the PDX? Let's check it out. The correct PDX is morbid obesity since the patient was admitted for bariatric surgery. As documented, the anemia and the retroperitoneal hematoma was noted postoperatively. Any CCs or MCCs? Let's check it out. Per documentation, the post-op retroperitoneal hematoma is an MCC. Reviewing the present documentation, are there any other potential queries? Let's check it out. If your answer is acute blood loss anemia, complication of procedure and chronic DVT, you are correct. If the provider responds to your queries, these are CCs. The clinical indicators for anemia is the low H&H, procedure performed, surgeon documentation of retroperitoneal hematoma and blood transfusion given. As for the query for chronic DVT, the clinical indicators are prior history of right lower extremity DVT on Eliquis prior to surgery. Additionally, Eliquis toxicity is not a potential query since patient confirmed that he did not take the medication 5 days prior to surgery, so this is not the cause of post-op bleeding. If you have any thoughts, email us so we can pass on your suggestions. Sample query for acute blood loss anemia. Query clinical indicators. Diagnosis: retroperitoneal hemorrhage. HNP, admitted for ovarian carcinoma in situ and prior history of anemia. Diagnostic workup: pre-op H and H 15.6 and 35.6, post-op H and H 8.6 and 22.1. Treatment: serial hemoglobin hematocrit, 2 units packed RBC transfusion. Based upon the above clinical indicators and your medical expertise, please clarify the best diagnosis for your patient. Some considerations include, but are not limited to: acute blood loss anemia, acute post-hemorrhagic anemia, other anemia not related to blood loss. Other explanation of clinical findings, please specify. Please use your independent clinical judgment when responding to this query. Thank you. Sample query for complication of procedure: if the provider did not clearly document that the post-op retroperitoneal hematoma is the complication of the procedure. Query clinical indicators. Diagnosis: retroperitoneal hemorrhage post-sleeve gastrectomy. Hospital Day 2 progress note indicates, patient experiences dizziness, hypotension, tachycardia. Diagnostic workup: pre-op testing, H and H 15.6 and 35.6 to current testing, H and H 8.6 and 22.1. CTAP reveals hyperdense attenuation, suspicious for hemorrhage. Treatment: urgent OR procedure for evacuation of hematoma. Based upon the above clinical indicators and your medical expertise, please clarify the best diagnosis for your patient. Some considerations include, but are not limited to: the retroperitoneal hemorrhage is associated with the procedure. The retroperitoneal hemorrhage is not associated with the procedure. Other explanation of clinical findings, please specify. Please use your independent clinical judgment when responding to this query. Thank you. Complication of care notes. Complication of care codes can be listed as the principal diagnosis or as a secondary diagnosis. It depends on the circumstances of admission. If the patient is admitted for treatment of the complication, then the complication diagnosis is listed as the PDX T code, followed by a secondary code if the complication code is not specific enough to describe the complication. Example: 58-year-old female admitted to the hospital for abdominal wound dehiscence following a hysterectomy 3 days prior to admission. The wound dehiscence, T81.321A, will be listed as the PDX. Case study number 3. 93 years old female presented to the ER with chief complaint of cough, congestion, past medical history of chronic diastolic heart failure, CKD stage 3B and stage 3 pressure injury to coccyx. Attending provider's assessment/plan indicates, admit to telemetry medical surgery unit for RSV pneumonia, continue broad-spectrum IV antibiotics, follow-up sputum culture results, CBC and chest X-ray. The patient has chronic diastolic heart failure, not an acute decompensation. CKD3B, renally dosed medications, stage 3 pressure injury to coccyx. Ordered wound care consultation. Wound care consultation notes the following: stage 4 pressure ulcer to coccyx. Wound care orders added into EPIC to continue wound care protocol. Let's find out the principal diagnosis, secondary diagnosis, and if there are query opportunities. What is the primary diagnosis? Let's check it out. Based on the documentation presented, the correct answer is RSV pneumonia. The patient was admitted with respiratory symptoms and treated with IV antibiotics. Chest X-ray result is pending as well as the sputum culture. The PDX may change depending on the chest X-ray result as well as the provider's documentation. The type of pneumonia may also change based on the sputum culture. Are there any CCs or MCCs? Let's check it out. Based on the present provider's documentation, there are CCs and MCC found. MCC is the stage 3 pressure injury to the coccyx. There are 2 CCs found, which are the chronic diastolic heart failure and the CKD stage 3B. Are there potential queries? Let's check it out. CDS can query of the stage of pressure ulcer on the coccyx since there is conflicting documentation between the provider and the wound care nurse. Provider documented stage 3 but wound care nurse documented stage 4. One potential query is the pneumonia. Provider documented RSV pneumonia. CDS should follow up the sputum culture. If the organism is different from the provider's documentation, the CDS can query for accurate diagnosis for the type of pneumonia. CDS should also follow up the chest X-ray result. It could be that the respiratory symptoms are due to heart failure and not pneumonia. If chest X-ray confirmed heart failure and is being treated and other clinical indicators for heart failure are present, CDS can query the provider the severity of the heart failure. Is it acute on chronic diastolic heart failure? Based on the provider's documentation, the patient is not in acute decompensation. That is why it is important that CDS do concurrent reviews to make sure that the CHF severity of diagnosis can be captured and not to miss the opportunity. Note: clinical indicators should be present to query the provider. Sample query for pressure ulcer confirmation. Diagnosis: pressure ulcer stage 3 to coccyx. Attending provider note indicates pressure ulcer stage 3 to coccyx present on admission. Wound care note indicates pressure ulcer stage 4 to coccyx present on admission. Treatment: wound care protocol. Based upon the conflicting documentation listed within the medical record, please clarify the best diagnosis for your patient. Some considerations include, but are not limited to: pressure ulcer stage 4 to coccyx is present on admission and patient does not have pressure ulcer stage 3 to coccyx. Pressure ulcer stage 3 to coccyx is present on admission and patient does not have pressure ulcer stage 4 to coccyx. Other explanation of clinical findings. Please use your independent clinical judgment when responding to this query. Thank you. Summary. Defined what is a HAC. Reviewed HAC examples. Discussed case studies with the possibility of querying for HAC diagnoses. Reviewed CMS quality measures and estimated costs hospital may lose with HAC diagnoses. Email us if you have any questions. This slide shows the resources and references used for this presentation. Thank you for watching. Make sure to click subscribe, follow and like to stay updated with our latest content. Click the link in the description below to obtain continuing education unit. The cost is $20 for one CEU.